So, in the previous part, we talked about what diabetes mellitus in pregnancy is, which is also known as gestational diabetes. So, we talked about this is the kind of diabetes that usually occurs or develops in the second and third trimester of pregnancy, where the blood sugar levels of the pregnant woman are raised. So, we talked about what it is, we defined it, and the pathophysiology. So we'll continue from there with the risk factors of gestational diabetes. So among the risk factors of gestational diabetes, one being a woman who is above 35 years. It is not well explained how being above 35 years is linked to gestational diabetes, but actually you need to know the fact that as we age, we are at risk for quite a number of conditions, and the diabetes mellitus usually develops as we age usually. So age, when you're above 35 years, you are at higher risk for developing gestational diabetes. Then number two, you have the previous history of gestational diabetes. This is well explained, where if you've had gestational diabetes in one of or two of the previous pregnancies that you had, it means you are at risk of developing this gestational diabetes even in this pregnancy. Then three, we have family history of type 2 diabetes mellitus. So in your family, if there is maybe your close relatives, your mother, your father, your uncle, your aunt, if they have type 2 diabetes mellitus, it means you are at a higher risk of developing this gestational diabetes. The other thing is obesity. So when you're obese, those who are obese, their cells actually they become a bit insensitive to insulin. They become a bit resistant to insulin. So obesity is just one of those risk factors for gestational diabetes. Okay. Then away from the risk factors, let's now discuss about some of the signs and symptoms. Actually, the signs and symptoms of diabetes, they are just like of gestational diabetes. They're just like those other forms of diabetes, diabetes type 1, diabetes type 2, just like that. So the first thing that we're going to have is this pregnant woman will be experiencing polyphagia, which is excessive hunger. So this woman, despite having a lot of glucose in blood, the cells are not utilizing them. So the body is going to interpret it to say, we don't have enough source of energy, we don't have enough glucose. So you need to eat so that we carry out our daily laws just like that. So the body will respond to that by this woman feeling excessive hunger. Then the other thing is polyuria, which is excessive urination. So what happens is that because in blood there is excess glucose, the kidneys will try to say, okay, let me help eliminate or excrete this excess glucose by filtering more and more fluids along with some glucose as well as some other electrolytes such as the potassium. So there will be polyuria as a result. The other thing that will be there is polydipsia, thirst, excessive thirst. So as a result, because you are urinating a lot, it means you are losing a lot of fluids. You are slowly becoming dehydrated. As a result, you'll be thirsty. So you'll be taking fluids, oral fluids. You'll be feeling excessive thirsty. Then the other thing that will be there will be dry skin and the mucous membrane. So this is just as a result of dehydration that has occurred due to polyuria, to excessive urination. Then the other thing that can be there, so in diabetes can present one in weight gain and weight loss. So remember we already talked about the issue of obesity, which can come as a result of excessive gaining of weight. Then as you go on, because the body is unable to utilize the glucose that is in blood, it can start using fats. It can start breaking down that fat, and you may lose weight. But mostly, what we are likely to experience in gestational diabetes is weight gain rather than weight loss. Then number 6, the sign and symptom that is going to be there is pruritus vulva. So pruritus vulva, this is just the itchiness that is there at the vulva there, you feel some itchiness. So that itchiness that is there is because of the bacteria. So you know the bacteria, they like sweet things. So because you are urinating a lot, it means that the urine that is coming out with some glucose with it. So there will be that multiplication of bacteria around the genital area. So this woman is actually at very high risk of urinary tract infections. She's at very high risk of developing urinary tract infection. Then the other thing that is going to be there is fatigue. You feel where you feel you don't have energy to do things. You're fatigued. So this is a result because the cells are not getting the glucose that is in blood. It is in blood, but it is not going to the cells because the cells are resistant to the insulin that is there. All that stuff. Why? Then, so the management of gestational diabetes, this is how we line up. This is how we line it up, the management of gestational diabetes. So remember, this is specific management. Specific management. So we no longer do the profinema, that thing. So we go it specifically. So you pick the important things. So the first thing that we'll talk about is the aims. Number 2, the investigations. 3, psychological care. The observations, the nutrition, about diet. Number 6, exercises. Then 7, medication. Then we go to the advice that we are going to give this woman, or the education, the information, education, communication that we are going to give to this woman. So aims. So what is going to be our aims as we manage this woman? So this is before delivery. So this is before delivery. So our aims will be 1, to control maternal blood sugar levels to normal ranges. So the normal ranges, we said it's between 7 to 11.1 millimole per liter. 7 to 11.1 millimole per liter. So that is for random blood sugar test, when you do the test randomly. Then for fasting blood sugar, it shouldn't exceed the ranges of 7. That's the normal. Then the other aim is to prepare this woman psychologically for possible forms of delivery, such as through C-section and preterm delivery. So remember, in our path of zero, we talked about this baby growing very big because it's receiving a lot of glucose. This baby being a microsomia, and the issue of the polyhydramnios. So this pregnancy is likely not to reach term. So you prepare this woman to say you might actually give birth to a premature baby, or you might deliver through cesarean section, or there might be complications such as fracture of the shoulders of this newborn, or the issues of the CPD, cephalopelvic disproportion, because of what is happening. So you prepare this woman for all that. Then the other aim is to eliminate or prevent infection. So remember, we already talked about the issue of the microorganisms multiplying and loving the sugar. So this one is likely to have some urinary tract infection. So we need to eliminate if they are there, or we prevent them. That's our aims. Then under investigation, so investigation, the first thing is, just like the other conditions, the first thing is we take history, get history from this woman. So history taking, where we will review the signs and symptoms that I know I've been urinating frequently, I've been feeling hungry for frequently, thirsty, I feel dehydrated, dizzy, I feel weak. All those things will be taken through the history taking part. So then physical examination, here we are going to focus on the issue of inspection, where you inspect the mucous membranes, where you are checking for signs of dehydration. Then the other thing that we're going to do is the RBS or FBS, so the random blood sugar test, or the fasting blood sugar test. The fasting blood sugar test, where we said this woman is made to fast for 8 hours straight without eating anything. Then you do the test. The random blood sugar test, you do it at any time. So we are going to look at those same ranges, the 7 and the to 11.1 millimole per liter. Then urinalysis, remember in urinalysis, you can also review glucosuria, which is glucose in urine, ketonuria, which is ketones in urine. And the presence of ketones in urine should worry us. It means that the body has started doing what? Utilizing fats. So when the body starts to use fats, when it starts to break down fats, it the end product or the fuel that is produced as the breakdown of fats occurs, it's what? Ketones. So the more ketones you have in blood, the more your blood becomes acidic. So the more likely this patient is likely to go into a coma. So that urinalysis needs to be done, as well as you look for the leukocytes, the white blood cells. How are the ranges of white blood cells? So an elevated level of white blood cells will reveal to say there are some sort of infection here. So the urinalysis will reveal all those things. Then an abdominal ultrasound scan also be conducted among the investigations, where you check for the growth of the baby. How is the baby growing according to the weeks? Is this the normal size of the baby, or this baby is a macrosomia? The baby is growing excessively. And you also check for the amniotic fluid. How is the fluid? Is it excessive or what? So you are going to note all that through an ultrasound scan. Then the other thing is you are going to look at, is this woman obese? So you are going to notice the obesity through the body mass index. So those are some of the investigations that you can do. Then now we go to the psychological care. So what are you focusing on during your psychological care? So one is the issue of anxiety. So maybe this woman is experiencing this diabetes for the first time. So you deal with anxiety. You explain what is happening and the possibilities. So no, this condition may resolve after you give birth, or it may not. You may develop diabetes type 2 in the future. So you deal with anxiety. Then you prepare this woman for all possible forms of delivery, like we've said previously. Then you prepare for life after delivery. So it all starts in the antenatal period, even the puerperal period. So after delivery, you'll be required to come to the hospital so that we monitor your blood sugar levels, if they are going back to normal, or all that stuff. Then the observations. So the observations here, take note, it depends with the severity of the hyperglycemia. The admission status of the woman, is she admitted, or has she developed any complications, such as is she in a coma? So that's what is going to determine how we observe this woman. So for example, a blood sugar checkup of at least twice a day is enough when this woman is admitted, or even at home. If they have a glucometer, they can do their blood sugar checkups at least twice a day, provided they are not in a coma. But if they are in a coma or in some sort of diabetic emergency, then the blood sugar checkup should be hourly. Even urinalysis here should be hourly, so that you eliminate all the ketones. Then the blood pressure profile, if they are admitted, it should be 4 hourly at least. 4 hourly, or once a day if not admitted. Or whenever they come for antenatal visits, you make sure you check the blood pressure. So the weight, whenever they come for the antenatal visit, there are those ranges of weight gain that a woman should gain during pregnancy. So you monitor the weight. How are they gaining? Are they gaining weight excessively? Are they not gaining according to the standards? So you check the weight. So it's also a part of the observations. Then we come to the nutritional diet. So in the nutrition, this is where you involve the nutritionist. So at the facility, at the hospital, there should be a nutritionist. Or if you are not, if the nutritionist is not there, then you yourself is going to be the nutritionist. Then you plan these diets with the pregnant woman, the relatives, maybe even the husband. So all in all, the diet should be rich in proteins and regulated carbohydrate intake. So this woman should have a regulated kind of carbohydrate intake, because carbohydrates increase what? Glucose. Then it should be low sodium diet, because we said these women, the more sodium they take, remember, because the glucose already, the sugars are already making this woman to urinate quite often. So if you increase the sodium is also going to increase the 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 urination part. So that we don't want that to happen. Then we continue. So we go to exercises now. So at least this pregnant woman should exercise at least twice a day, depending on the tolerance. So you can't tell a pregnant woman who is in a coma. For example, the question states to say this woman, because of the diabetes, she has gone into a coma. So I don't think it's justified for you to tell a person who is in a coma or in a confused state to exercise. So if they are in a coma, when they recover, they should at least exercise twice. Why? Because exercises helps with the sensitivity of the cells to insulin. So cells become more and more sensitive to insulin as we exercise. So then we go to medications now. So there are classes of anti-diabetic drugs. So we have the biguanides and some other form of classes. So I want to go further into pharmacology. So among the medications that you're going to give to this woman are antidiabetics, so such as metformin at a dosage of 500 milligrams twice a day or 3 times a day, depending on how they respond to this metformin. So if they don't respond well, you increase it the frequency to 3 times a day. Then you can also give glibenclamide down 5 milligrams down 5 milligrams once or twice a day. So take note, this metformin and Downy, they have different ways of acting. So the metformin, the way it works is it reduces the production of glucose by the liver. So it inhibits the production of glucose by the liver because we already have glucose in blood. So it inhibits the production of glucose by the liver. Two, it also reduces the absorption of glucose in the intestines. So when you have a carbohydrate meal, instead of a lot of carbohydrates, a lot of glucose being absorbed into blood, this metformin is going to inhibit that action. It's going to inhibit that action. With downhill, the mode of action is that it increases the production of insulin. The production of insulin, meaning we have an increased number of maternal insulin that is being produced. That is going to help with the sensitivity of the cells to this insulin, the absorption of this glucose into the cells. So these two drugs, they work better together. Metformin can do the job alone, but mostly when you combine metformin and downhill, that's when you notice some quick action. Then if there is an infection, you can give broad-spectrum antibiotics such as the cephalosporins, the ceftriaxone, cefalexin, all those drugs. So the dosage would depend on what type of infection you've noticed. So you can give, if for mild infections, ceftriaxone 1 gram once daily, because we don't want to overdose this one with broad-spectrum antibiotics, because remember, these antibiotics, they have also what we call teratogenic effects. They can also affect the well-being of the baby. They can also affect the baby. So you clearly regulate the type of infection that is there. Is it severe? You can do the 2 grams per day. So you do the benefit and the risk you weigh. Then in some cases, in rare cases, insulin may be administered, more especially when a woman is in a coma. So you may give the insulin hourly, depending on the calculation. Then what advice do you give to this woman? So one, you talk about nutrition. So I think I want to focus much on nutrition part because we've already talked about it. So we want a protein-rich diet, but well-regulated carbohydrates. So you tell them, no, you need to reduce on your carbohydrate intake. So these are the foods that you should be eating. So you discuss with them the type of foods that they are able to manage to get, or the type of foods that are easily accessible. Then you also talk about the issue of medication adherence. So remember, they take this, it's not forever. If they are lucky, it's not forever. It may resolve after delivery. Then you also talk about the fact to say, no, this is a risk pregnancy, so this pregnancy should be delivered at the hospital because it may be through a cesarean section, or there may be issues of the CPD where the pelvic disproportion, the baby fails to descend further, fails to negotiate the pelvic region, and it may result in even death. The labor be prolonged. Then you also talk about the issues of infection prevention, hygiene, all that stuff, everything to do with infection prevention. Then also the danger signs. So you tell them to say, no, you may develop, you may notice some danger signs, such as maybe the lack of membranes. They may be in the 7th month, then they notice to say the fluid starts coming out. So that's a danger sign because of the complication that has resulted as because of the diabetes. So you tell them even about the danger signs in the IEC. So then let's now talk about the complications. So the complications that we are going to talk about them is we have the maternal complications as well as the fetal complications. So among the maternal complications is hypertension. So hypertension may result as a result of DM. Remember the kidneys are involved, all that stuff. So the hypertension may occur. The issues of preeclampsia can also occur. Then also diabetes, they are likely, they are at risk. Once you have gestational diabetes, it means you are at risk of developing diabetes mellitus type 2, mostly in the near future. Then a complicated delivery such as a cesarean section or all those other types of delivery. Then the other complication that can be there is infection. I think we've talked enough about the issue of infection, how it comes about. These microbial activity in response to the sugars. In the fetal complications, we have the issue of the respiratory distress syndrome. So remember, this baby is peeing a lot. It's peeing a lot, and they might be delivered prematurely before the surfactant of the lungs is well made. Before that surfactant in the lungs is well made, so they may have some form of respiratory distress syndrome. Then microsomia, this is very likely because this baby is getting a lot of glucose. They might have a big baby. Then fracture of the shoulders, mostly fractured shoulder. As you try to force the spontaneous delivery, you fracture the shoulder. Then hypoglycemia after delivery. So remember, we no longer have the mother who is providing this baby with those glucose. And then the baby, remember in our pathophysiology where we said the baby starts to produce quite a number of insulin, high levels of insulin in response to the increase the level of glucose in blood that it is receiving through the placenta. So now the placenta is no longer there to provide this baby with all that glucose, and then you have a lot of insulin. What is going to happen? The baby is going to go into hypoglycemia after delivery. Even still, the chances of giving birth to a dead baby are very high. Then the other thing that can be there is polyhydramnios, which is excessive amniotic fluid. Then prematurity, I think we've talked about this. Even childhood obesity. So as they grow, during just their childhood, you see the baby is very obese. So all that stuff. So I think this is what remained in the diabetes mellitus.